like to invite our first speaker, Dr. Supriya Sharma. She's our cornea faculty at Shantilal Sangvi Eye Institute. Her core interest is ocular surface disorders, and she'll be speaking on cataract surgery in difficult ocular surfaces.
Thank you, Weber. A very good afternoon, everyone. So my topic for today is cataract surgery in ocular surface disease. A normal, healthy ocular surface consists of normal eyelids, meibomian glands, eyelashes, a non-keratinized epithelium of lining the cornea as well as the conjunctiva, and a healthy tear film. Any derangement either in the structure or function of any of these structures can result in a variety of conditions. Together they are termed as ocular surface disease. So why are we here talking about cataract surgery in ocular surface disease? Now, cataract and dry eye disease, dry eyes is often seen in any form of ocular surface condition, may coexist particularly in the elderly population. Any kind of ocular intervention or cataract surgery here may cause worsening of these symptoms, and these symptoms will last up to 6 months. So you do not want a patient who has recovered 20/20 but has still persisting symptoms of either redness or chronic irritation, watering in the eye. And this has been proved by several studies where more than 50% of the patients who were asymptomatic at the time of cataract surgery had either an abnormal T-butt or a tear osmolarity or a meibomian gland dysfunctioning. Now, what causes worsening of dry eyes at the time of cataract surgery? It is the corneal nerve transaction, inflammation, loss of goblet cell density, phototoxicity when the surgery has gone on for a very long time or you have kept the illumination or from the operating microscope a very high, meibomian gland dropout, and toxicity from the preservative medications that are used. What causes cataract in these conditions can be either because of chronic use of steroids, because of the disease per se, because of chronic inflammation, or it could be just age related. What are the challenges that you face while operating on such patients? The most important is inaccurate biometry, poor visibility. Then you have to deal with what type of cataract surgery do you want to do in these patients and what kind of lens would you want to put in these patients. So preoperative evaluation is very important. It is important that you ask specifically each and every patient if there is history of dryness, grittiness, burning in the eye, itching, whether there are any kind of systemic medications related to eye or even not related to the eye for that matter, and there is a history of any previous ocular corneal refractive surgeries that they have undergone. Evaluation of the eyelids and eyelashes is extremely important because you have to be aware if there is presence of blepharitis, you need to take care of these conditions before you go ahead with the cataract surgery. Subtle changes like you can see here, presence of subconjunctival fibrosis, there is presence of symblepharon, or changes in the medial or the lateral canthus can actually be subtle clues that may be present in early stages of cicatricial conditions. Assessment of the cornea becomes very important in these cases to rule out scarring if there is any thinning, focal or a diffuse limbal stem cell deficiency. Conjunctivocalasis, these patients will always present with worsening of symptoms, watering, burning sensation after the cataract surgery. Staining is one of the most important tests that every patient should undergo because this actually tells you whether there is involvement of the cornea, that is keratopathy, or the patients have dry eye disease without keratopathy. So in the first scenario, when the patient does not have corneal involvement, it is important that you differentiate whether it is an evaporative or an aqueous deficiency dry eye. If required, perform an immune screening test in this and initiate immunomodulatory therapy before you go ahead with the surgery. This also prepares you to perform simultaneous punctal cautery or using punctal plugs at the time of surgery if required. If there is presence of keratopathy, then we are sure that there is some underlying disease which has not been diagnosed yet, and then you go ahead with a detailed history and clinical workup, refer to a rheumatologist if required. Sometimes these patients may already be on immunomodulatory therapy and you may have to step up this IMT at the time of surgery. Counseling is extremely important in these cases because you have to explain the patient about the post-operative symptoms that they may worsen for some duration after the surgery, the prolonged post-operative care and need for additional medications which may be required in these patients. Also another thing is to explain them is to have realistic goals that they may need glasses or contact lenses or scleral lenses eventually for visual rehabilitation. Coming to the biometry, in dry eye disease which do not have corneal involvement, so ideally an A scan or a biometry should be performed before any invasive procedure like GAT or staining of the ocular surface, possibly in an undilated pupillary state, and repeat scans till you have minimal variation in between two scans. If there is involvement of keratopathy, then sometimes when you have very steep corneas, it is better to take the keratometric values from the pentacam and use them for your calculation of the IOL power. In case of dense scarring, standard keratometric values can be used, and then you explain the patient that they may be need of glasses or contact lenses after the surgery. If the media clarity is not clear, it is absolutely okay to leave these patients aphakic and then visually rehabilitate with contact lenses eventually. So this is a surgical video where phacoemulsification was performed in a patient with ocular cicatricial pemphigoid. As we can see, there is scarring and vascularization of the corneal surface. So when you are making your side port incisions, typically look for areas where there is no vascularization because you want to avoid or keep the bleeding to minimum. Keep the illumination low. Use trypan blue to enhance visualization in these cases so that when you are making your Rexes, there is minimal chances of it running out. Frequent use of saline and viscoelastic is advocated because you do not want any epithelial defect. A good hydrodissection hydrolation is the key here, that reduces your surgical time. Magnify whenever in doubt because you don't want to deal with a PC rent in such cases, and do the phaco part is like a routine cataract surgery, but the cortical aspiration should be extremely slow so that again there's no risk of PC rent in these cases. The choice of intraocular lens again depends, but obviously we need to avoid multifocal lenses in these cases because we are not sure of what are the post-operative visual outcomes in this. Suture all the main as well as the side wounds because there's scarring and there's a higher risk that these wounds may leak after the surgery. If there is any doubt, you always need to double check. For example, here where I was not sure whether it is the wound leaking or a blood vessel leaking, you can always use betadine and you see the aqueous gushing out of the side port. So here you need to take typically longer bites and much more deeper bites to ensure that you attain a watertight closure. So here the idea to show this video is that many times it happens that the cataract gets neglected because you're trying to visually rehabilitate the surface. So then you will have to deal with mature cataracts where they are not left with the option of doing a phaco, and you would have to just do SICS in such cases. And these patients may obviously need additional iridectomy in some cases where the scarring involves the visual axis. The surgery is same as you would routinely do, and again the same thing, I always ensure that you are closing all the main wounds as well as the side ports in these cases. So just to conclude, cataract surgery is challenging in some cases, but it's important to have a comprehensive approach in these to provide better visual outcomes and reduce the possibility of complications whenever possible. Surface stabilization is very important in terms of controlling the surface inflammation before you plan any surgery, because you don't want to deal with non-healing epithelial defects, corneal breakdown in such cases. And it's important that you counsel these patients so that they have realistic expectations and they know what they are undergoing. Thank you. So if there are any questions, I'll be happy to take them.
Yeah, thank you, Dr. Supriya. So one question for you would be, we had a bit of clarity in these corneas. What is the role of endo-illuminator or chandelier illumination? Do you think there is any role in cataracts with poor corneas?
Personally, I don't have any experience with using endo-illumination, because when there is an early cataract, I think the microscopes which have the option of retro-illumination, it works pretty well. And in mature cataracts, using an endo-illumination like a pars plana would not serve the purpose, but when you try to put it in the anterior chamber, there will be more crowding. So these cases anyways have either a disorganized, I'm talking of the advanced cases, they have either a disorganized anterior chamber, and there is very, very minimal room for any kind of manipulation. But if other panelists have any experience.
Your opinion on
I thought very well presented, Supriya, and nice cases. But Dr. Lahani also presented in the pre-lunch session a beautiful case that where they had used the endoilluminator, but the retinal from the retinal surgeon. So that is very handy if you have a retinal surgeon next to you. Failing that, I think that the technique that you suggested using the endoilluminator from outside works well. And I also wanted to ask you that what Dr. Lahani said in the morning. So he said that the younger generation will do phaco for all of these cases. But what is your tip?
So, for wherever you feel that the cataract is early, that's exactly the point that I wanted to highlight. That always, once you are sure that the surface is stabilized, always try to go in for an early cataract surgery, because the earlier you plan, the better it is for you to perform a cataract surgery. And phacoemulsion, clear corneal wounds basically heal faster and much better as compared to SICS or ECC wounds, because they tend to cause more inflammation in an already compromised ocular surface.
Any audience questions?
To reduce the vascularity of the surface, would you inject mitomycin? That MIC technique has been described where intravascular mitomycin is injected, or any other thing to reduce the surface vascularity?
No, for surface vascularity, I have never personally used mitomycin because I feel it causes more of, it would probably cause scarring, I'm not sure. But when you have surface cases and for superficial vascularization to reduce the bleeding, you may probably use brimonidine eye drops. Otherwise, most of these cases have deep stromal vascularization, for which you really can't do much in these cases.
Brimonidine just pre-op, but longer
Yeah,
term
so
CME.
typically for surface cases, we start using probably half an hour before, at intervals of every 5 to 7 minutes, you can start using these drops, and it works beautifully in such cases, reducing, especially when you have to go ahead with SICS. So the amount of bleeding is much less in these cases.
Or a fine needle cautery or something before.
So, cautery use in compromised ocular surface should be kept to minimal, because you again don't want to incite or induce inflammation in these cases. But of course, whenever it's compromising your field of surgery, if there is too much bleeding, then probably you can go ahead with using like cauterizing only the bleeders in those cases.
Thank you.
I think the question was about FNDT. So FNDT for these cases, again, exactly as Supriya said, that preoperatively we do 2-3 rounds. But that is for vascularized scars and ocular surface cases. You would probably avoid doing FNDT, fine needle diatherm.